Hello and welcome to this lecture of neurological examination. In this lecture, we are going to address examination of the sensory system. Firstly, modalities of sensation can be categorized into superficial sensations, which include pain, touch, and temperature. Deep sensations, which include vibration, muscle, joint, and nerve sensation. Cortical sensations, which are a group of interpretative sensory functions that require analysis of individual sensory modalities by the help of sensory association areas. Here are some definitions of the most common sensory abnormalities. Allodynia, increase in sensibility to pain or pain in response to a stimulus that is not normally painful. Analgesia is absence of sensibility to pain. Hypoalgesia is decrease in sensibility to pain. Hyperalgesia is increase in sensibility to pain. Anesthesia is absence of all sensations. Dysesthesia, it's an unpleasant or painful, abnormal, perverted sensation, either spontaneous or after a normally non-painful stimulus, as burning sensation in response to touch stimulus. Paresthesias, they are a group of abnormal, spontaneous sensations experienced in the absence of a specific stimulation, as feelings of cold, warmth, numbness, tingling, burning, prickling, crawling, heaviness, compression, or itching. There are some general rules and instructions for sensory system examination. The patient must understand the procedure and be cooperative. Examination has to be done while the patient is completely relaxed and with his or her eyes closed. It is better to start the examination at the areas of lesser sensitivity and proceed to those of better sensitivity. Instruct the patient to identify a difference in the strength of sensation from one area to another. We have to compare both sides and examine each dermatome separately. All of this is to aim at detecting a certain pattern of decreased, exaggerated, or perverted sensation. Methods of examination of touch and temperature are as follows. Touch can be examined by a wisp of cotton or a soft brush, and the patient is tested if he can recognize the stimulus, and this is for crude touch, and localize the stimulus, and this is for fine touch examination. While temperature can be tested by using test tubes containing warm and cold fluid, or they can be examined roughly using the prongs of the tuning fork, which is usually colder than the environment. For examination of vibration, we use a tuning fork of 128 Hz frequency. We strike the fork and then place it at a bony prominence and hold the fork to this prominence until the patient no longer feels vibration. We repeat the test at a proximal point and compare both sides of the body to each other. We start distally by examining the base of the big toe, and then we proceed proximally at the malleoli of the foot, and then the tibial tuberosity, iliac spines, the sacrum, vertebral spines, and the clavicle. For the upper limb, we can examine the finger heads, stylite processes of the radius and ulna, and the malleoli. We have to make sure that the patient receives or perceives vibration as such and not as touch sensation. Examination of joint sense, which is another modality of deep sensation. Joint sense involves two types of sensation: sense of position and sense of movement. For the lower limb, grasp the patient's big toe on its sides between the index and the thumb to avoid its contact with the neighboring toes. Ask the patient to look at his toe and explain the test to him, then ask him to close his eyes. Change the position of the big toe up and down and ask him whether he can recognize a movement or not. And this is for testing the sense of movement, and to recognize the new position to test the sense of position. If impaired, move proximally to test the ankle joint. For the upper limb, we test the thumb or the fingers in a similar manner by starting at the distal interphalangeal joints, and then we proceed proximally. Romberg's test, it is a special test developed to detect sensory ataxia, and sensory ataxia means incoordination due to affected deep sensation. The patient is able to stand with feet together and eyes open, but when he is asked to close his eye, the patient starts to sway. This may be one of the earliest signs of posterior column diseases. You can help detect milder degrees of affection by asking the patient to extend his arm forwards while performing the test. This is a more challenging position. Muscle and nerve sense can also be referred to as deep somatic pain. To examine muscle sense, we squeeze or pinch a muscle, which is usually the calf muscle, and normally a disagreeable and discomforting sensation is produced. Loss of this sensation may occur in some conditions, as in neurocephalus and peripheral neuropathy, and is termed a Badis sign. Nerve sense can be tested by delivering pressure on superficial nerves, as the ulnar nerve behind the medial epicondyle, and it also usually produces a discomforting sensation or an electric sensation. Examination of cortical sensations, they are only examined if there is intact superficial and deep sensation. All the tests have to be done with the patient's eyes closed. To test tactile localization, prick the patient's arm and ask him to localize exact site of the prick. 2-point discrimination. Use a compass to deliver 2 simultaneous pricks, and then increase the angle of the compass gradually until the patient perceives 2 pricks, not 1 prick. We try this at different areas of the body. Stereognosis. We ask the patient to recognize a familiar object placed in his hand as a key or a pen. To examine graphesthesia, we ask the patient to recognize a letter, number, or a figure drawn over his palm by the examiner's finger. To examine perceptual rivalry, you deliver simultaneous pricks at 2 corresponding sites of the body of the patient. Normally, he feels both of them. In case of cortical sensory loss, only the prick on the healthy side will be felt. These 2 diagrams show the pathways of fine touch and proprioception, and pain and temperature until they reach the primary sensory areas in the brain. For fine touch and proprioception, they are illustrated in the diagram on the left. As we see, fibers carrying fine touch and proprioception ascend in the spinal cord without crossing until they cross at the level of the brain stem. Therefore, a lesion in the spinal cord causes ipsilateral loss of proprioception. For pain and temperature, as we see in the diagram, the fibers cross the spinal cord to the opposite side at the same level of entry of the fibers, and then they ascend on the contralateral side of the spinal cord as the lateral spinothalamic tract. Therefore, a lesion affecting the spinal cord causes contralateral loss of pain and temperature below the level of the lesion. A very important term is sensory dermatomes. A dermatome is an area of skin that is mainly supplied by afferent nerve fibers from a single dorsal root of the spinal nerve. The following are important keys that help to detect the affected dermatomes. C1 gives no supply to the skin. The occiput is supplied by C2 in addition to the angle of the mandible. C5 supplies the outer aspect of the shoulder tip. C7 supplies the middle finger. T8 supplies the rib margin. T10 supplies the umbilicus, and T12 supplies the pubis. S1 supplies the little toe. S3, 4, and 5 are in concentric rings around the anus. This diagram shows dermatomes at the front and back of the body. This diagram shows different patterns of loss of sensation. The first row, from the left to the right, we start by thalamic sensory loss. In thalamic lesions, sensory loss happens to be on the opposite side of the lesion and involves the whole body. In the second diagram to the left, brainstem lesion causes what is known as crossed hemihypothesia. It leads to contralateral sensory loss below the face and ipsilateral loss on the face. For central cord lesions, which involve the crossing pain and temperature fibers, they cause what is known as jacket sensory loss. It is localized to a certain area of the body and is dissociative in nature. For pain and temperature are lost while touch is intact. In case of hemisection of the cord or a unilateral cord lesion, it causes what is known as Brown-Séquard syndrome, and it leads to contralateral pain and temperature loss with ipsilateral weakness and ipsilateral dorsal column affection below the level of the lesion. A transverse cord lesion causes what is known as a sensory level, which means loss of all types of sensation below the level of the lesion. In case of dorsal column lesions, as in multiple sclerosis, loss of proprioception, vibration, and light touch occurs below the level of the lesion. And there is also the dermatomal sensory loss, where a certain area supplied by a specific nerve root is affected. In case of polyneuropathy, which is the right and low diagram, in this case, stuck and glove hypothesia occurs, or distal sensory loss. Here we come to the conclusion of this presentation. Thank you very much.